nice introduction. I'm going to talk about anemia in diabetes. Now, this is a important talk, but it is often neglected. And you can see that the anemia is rarely evaluated in the diabetic subjects. So this, if I look into one very interesting paper published about a decade back, then this paper has actually highlighted the important issue that the anemia in patients with diabetes remain unrecognized, undetected, and untreated. I 100% confirm with this observation. As we can see, most of the diabetic patients are rarely tested for anemia. This is number one, because in most of the situation, testing hemoglobin is not in our recommendation. And second issue is that even if the anemia is detected, very rarely patient receives the treatment for anemia. And third important issue is that we understand that anemia has got an impact on the quality of life of the patient with diabetes. So therefore, it is an important issue in front of us. And at the same time, we have to understand that it is not recognized, remain undetected, and often remain untreated by majority of us. Now, whenever we talk about anemia, we always think about glycosylated hemoglobin. Now, if someone has got an anemia, what will be the impact on glycosylated hemoglobin? So we know that the HbA1c level increases in the iron deficiency anemia, because in iron deficiency anemia is associated with increase in the lifespan of the RBC. So it increases the HbA1c level. So if you detect HbA1c, and if you find that HbA1c is high, and on the basis of that, if you diagnose a case as diabetes, then quite naturally you will diagnose diabetes wrongly. And background iron deficiency anemia actually overestimate the diagnosis of the diabetes. So we have to first we diagnose HbA1c level. And HbA1c is a very important marker of glycemic control. So whenever we set a treatment goal on the basis of HbA1c, we have to remember that the anemia has got a significant impact on HbA1c, and therefore anemia should be corrected before we set the treatment goal of optimum HbA1c control. And lastly, that the strict HbA1c control is not recommended in anemic patient before it is corrected. So therefore, these are the important issues. These are the important relationship between the anemia and the HbA1c. With this introduction, I will talk about the anemia in diabetes, its prevalence, the impact of anemia on complications of the diabetes, what is the pathophysiology of anemia among the diabetic subjects, and I'll discuss few case studies, my experiences of anemia and diabetes, and then I will wrap up with the take-home messages. So if we look into the prevalence of anemia among in the Indian subcontinent, we find that the anemia is quite common in our country. It is more in preschool children, in adolescent girls, in pregnant women, reaching almost 100%. And in the men also, it is not very uncommon. So therefore, anemia has got a very high prevalence in our country. And if we look into diabetes mellitus, the diabetic patients have got a higher risk of anemia compared to non-diabetic counterpart. And patients with poor glycemic control are actually have higher risk of developing anemia than patients having good glycemic control. And risk of anemia further increases with the onset of the kidney disease. So whenever we talk about anemia, it comes in our mind about the diabetic kidney disease. So whenever there is a diabetic kidney disease, the possibility of anemia will become higher, because of the fact that the kidney is responsible for a very important factor, erythropoietin, which is responsible for the stimulation of the bone marrow for production of RBC. So once there is a kidney disease, the production of erythropoietin is low, and therefore this important factor which is responsible for erythropoietic process is not there, and therefore the patient develops anemia over a period of time. Now this is basically the categories of anemia: mild, moderate, and severe. We have to ask for complete blood count to decide the types of anemia. Second, we have to evaluate the comorbid conditions, especially the kidney disease. So presence of kidney disease is a very, very important risk factor for the development of anemia. And third, we have to check the medication history. Some of the drugs which we commonly use in the diabetic subjects are associated with the development of anemia. So the second part of the agenda is the impact of anemia on diabetes complications. The question is, if someone have anemia, what will be the effect of the anemia on the diabetes complications? Now, there are a lot of data and evidences in favor showing that the presence of anemia actually responsible or one of the important risk factor for the progression of diabetic nephropathy. So it has got a dual relationship. A patient who have diabetic kidney disease are more prone to develop anemia because of the problem with erythropoietin or erythropoietin deficiency. At the same time, if there is an anemia, anemia itself is a risk factor for the progression of diabetic nephropathy. Then there is a relationship with the retinopathy progression also. We have a lot of evidences that the anemia is associated with retinopathy progression, and it actually is a risk factor for the progression from non-proliferative diabetic retinopathy to vision-threatening diabetic retinopathy. And if we look into this important observation, we find that not only the retinopathy and the nephropathy, but also the neuropathy are actually affected by the anemia, and their probability of having this microvascular complications is higher if the patient is suffering from anemia. So all the microvascular disease, nephropathy, neuropathy, and retinopathy has a strong association with that of the anemia. Not only that, if we look into the cardiovascular disease, anemia is a risk factor for the development of cardiovascular disease. The publications are there both from the kidney side and also from the cardiological side. So we all know that the presence of anemia can precipitate the angina. Presence of anemia can precipitate an heart failure, and we all know that the diabetic patients are more prone to develop cardiovascular disease, especially the atherosclerotic cardiovascular disease and the heart failure. So therefore, correction of the anemia is a very, very important among diabetic subjects, because it is closely linked with many complications of the diabetes. And very importantly, we find this study which has actually looked into the relationship of anemia with that of mortality. And after adjustment for other independent predictors, anemia was associated with 57% increase in mortality. So anemia is not only linked with that of different complications of the diabetes, anemia is not only linked with that of the false interpretation of HbA1c, but the anemia is linked with that of the increased mortality. So that is the importance of anemia when we look into our type 2 diabetic subjects. Now coming to the pathophysiology, why there is anemia. As I have already discussed, that one of the important risk factor for the development of anemia is definitely the chronic kidney disease. Now, as you can see in this chart or in this publication, that with the progression of the renal disease, with the gradual decrease in the GFR, there is a gradual increase in the prevalence of anemia. As we all know that the kidney is responsible for the production of erythropoietin, and which is basically impaired in among the patients who is suffering from chronic kidney disease. And this relationship of anemia with that of the advancement of the renal disease is there with both type 1 and type 2 diabetic subjects. Apart from this renal component, now the production of the erythropoietin. Apart from this effect of the erythropoietin or the reduced renal production of erythropoietin, there are many other contributing factors present for the development of anemia among diabetics. Now you can see that the diabetic patient has reduced red cell survival, hematinic deficiency, reduced iron availability, systemic inflammation. So anemia can develop from inflammatory process, because in inflammation there is a bone marrow suppression. Then occur blood loss, which sometimes occur in diabetes, especially if the patient have got a chronic kidney disease. Celiac disease is associated with malabsorption. Some drug therapy like renin-angiotensin system blockade or thiazolidine-dione can cause anemia. Hemodilution can cause anemia because of the fluid overload. So there are many other risk factors which contributes to the anemia among patients with diabetes. However, another very important issue is the after the bariatric surgery. Now you can see after many patients who have actually diabetes mellitus, they actually undergo bariatric surgery, because bariatric surgery is an important method by which they can reduce their body weight. So in patients who undergo the bariatric surgery, they often suffer from anemia. And as we can see in this publication, that the anemia affects as many as 2/3 of these patients. And the topmost cause is definitely the iron deficiency disease. But obesity itself may be responsible for the development of chronic inflammation and the anemia, and it is the anemia of chronic inflammation. Anemia may be because of the micronutrient deficiency, which are often present after the bariatric surgery. And lastly, the folate or vitamin B12 deficiency can also be there. Though the vitamin B12 deficiency and folate deficiency are very infrequent, but they may be present and may contribute to the development of anemia. And then we have these two important drugs, the ACE inhibitor and ARB. And ACE inhibitor and ARB both are actually associated with development of anemia. So these are the very common medication we use. I am not saying that we should not use these drugs. What I am saying, I am highlighting the issue that when you are using ARB on ACE inhibitor, it may contribute to the development of anemia. Sometimes I have seen some nephrologists don't want to give ACE inhibitor or ARB because the fact that it has got a significant contribution towards the development of anemia. And as we all know, that the presence of anemia is associated with further progression of the renal disease. So if we look into the cause of the anemia among the diabetic subjects, it is basically multifactorial. Definitely the one of the important causes is the chronic kidney disease, but the other causes are also operative for the development of anemia, like chronic hyperglycemia, oxidative stress, abnormal RBC lifespan, the use of the drug which we commonly use among our type 2 diabetic subjects, and there may be some chronic inflammation. As we know that the chronic inflammation is a part and parcel of diabetes mellitus and obesity, and can lead to anemia of chronic inflammation. And at the top of the list is definitely the erythropoietin production and decrease in the erythropoietin activity. So all these factors jointly contribute for the development of anemia among the diabetic subjects. So with this, let me look into the case studies and my experience of anemia with diabetic subjects. This is the first case, a 34-year-old woman, diabetics for the last 4 years, hypertensive for the last 2 years, having regular period. She had one child on metformin, glimepiride, telmisartan, mild dyspnea on exertion, obese, blood pressure normal, other system examination was normal. When we check this patient, we find that the hemoglobin was 8.7. Possibly it is because of this low hemoglobin. Patient is having mild dyspnea on exertion. Glycemic control is fairly good. Renal function is normal. Thyroid function normal. So when you see that someone is suffering from anemia, what should be our next step? The next step is to identify the cause of anemia. Now, if we look into the causes of anemia, the causes of anemia among diabetics are many, but we should follow some kind of algorithm to reach to that diagnosis. You will find lot of algorithm available for the approach of anemia, but I use this one, so I will discuss this one. Now, the best thing after the detection of anemia is to look for the MCV, or mean corpuscular volume. Now, this mean corpuscular volume less than 80 femtoliter indicates that we are dealing with a microcytic anemia. If it is between 80 to 100, then it is a normocytic anemia. And if it is more than 100 femtoliter, it is basically a macrocytic anemia. So we will review the history. We'll check the CBC, the mean corpuscular volume, and reticulocyte count. And then we have to decide that whether it is a microcytic anemia, normocytic anemia, or macrocytic anemia. So coming back to the case, so we have evaluated this patient for the mean corpuscular volume, and we find that it is 74.7, indicating that we are dealing with microcytic anemia. And at the same time, we have looked into the serum ferritin value, which was quite low, 9 nanogram per ml. Therefore, we can think that possibly we are dealing with a microcytic hypochromic anemia due to iron deficiency. So when we have the diagnosis of iron deficiency, we will try to correct it, and before we correct, we must have a target hemoglobin. So this is basically a position statement published very recently, and our target hemoglobin will depend on the age, clinical status, and treatment response of the subject. It is basically individualized. Having said that, in most of the situation, I think our target hemoglobin should be 11 to 12 gram per dl, and we should not overcorrect the hemoglobin. Rather, we should undercorrect the hemoglobin. So we will not make the patient high hemoglobin or more than 13 gram per dl level of hemoglobin, because high level of correction or excess correction may be associated with certain adverse consequences, especially so if the patient has got a diabetic kidney disease in the backdrop, and if you raise the hemoglobin level more than 13, then it is associated with cardiovascular complications and mortality. So therefore, in majority of the situation, our target is 11 to 12. And in patients with diabetic kidney disease, actually I target between 10 to 11. So that is a better target in diabetic kidney disease. And in all other situations, 11 to 12 is a very good target in front of us. Now, while we treat the iron deficiency, then we have two options in front of us. One, either to give oral iron or to give intravenous iron. Now, both the preparation has got lot of advantage and disadvantages. Now, oral iron is effective in most of the patients. Similarly, the IV iron is also effective in the most of the patient. Now, the second issue is that we do not have intramuscular iron preparation available right now. So we do not use intramuscular iron. Neither the intramuscular iron preparation is recommended nowadays. So we have two options, either oral iron or IV iron. We don't treat our patients with intramuscular iron. Now, if we look into the oral iron therapy, they have a very low risk of adverse events, and they are very, very cheap. So this is one of the very, very important advantage of the oral iron therapy. But the oral iron therapy may be associated with more gastrointestinal side effects, especially if we're using the our age-old preparation, that is the ferrous sulfate. So the compliance may be low, and often if the patient has got a severe anemia, then oral iron may be inadequate. And often the iron therapy requires for a long period of time if you want to correct the anemia with that of the oral iron preparation. We have some better iron preparations available to us: ferrous fumarate, ferrous gluconate, or ferrous ascorbate. Now, the ferrous ascorbate is available in the market in Husit Fe, is definitely a very good choice for oral iron therapy. Now, when we look into the IV iron, there are three options in front of us. Ferric carboxymaltose is very commonly available to us, and we can give up to the dose of 1000 milligram elemental iron in a single infusion. It should be given intravenously. As I've told you, it is effective in most of the patient. Rapid correction is possible, compliance is assured, and as it is intravenous, no gastrointestinal side effects as we find with the oral iron preparation. However, we have to monitor the intravenous infusion. Some cases of allergic reactions may be there, and it requires an equipment and the personnel to treat the allergic and infusion reaction. And lastly, the cost of IV iron therapy is much higher compared to the oral iron preparation. Coming to my second case, let us take the same case, the same patient, only issue is that this patient has got a if we look into the hemoglobin level 8.7. So if when we do a further evaluation of this test, this patient will find that this patient has got again the low mean corpuscular volume, indicating we are dealing with a microcytic anemia. But when we look into the serum ferritin, it is 167, indicating the patient has got enough iron store. So therefore, we are looking for a patient who actually appears to be iron deficiency anemia, means microcytic, but the normal or adequate iron store. So the microcytic hypochromic anemia, and we are looking for the cause of this anemia. Now, the second most important cause of microcytic anemia is the thalassemia. So we have to ask for hemoglobin electrophoresis, and this patient actually had beta thalassemia minor. Now you can see that the thalassemia minor is basically not a very serious disease. It remains undetected for a very long period of time. I have detected beta thalassemia minor in many of our patients who are above the age of 40 or above the age of 50. So therefore, it is not very uncommon. The very, very important issue is that we should not treat this patient with the iron. So we should avoid the iron preparation for the management of beta thalassemia minor. This is number one. Number two, we should give folic acid supplementation for the lifelong. If the patient has got a concomitant iron deficiency, then and then only we should correct this iron. And lastly, but not the least, is the counseling of the patient. Now, if the patient is in the childbearing age, either male or female, you have to counsel the patient, and if they desire to have their own baby, then they should check the thalassemia of their partner. And if the partner also have thalassemia minor, then quite naturally it will be a risky affair to have a child, but they have to take some precautions for that. Now, so genetic testing and counseling is an important issue when we have detected a beta thalassemia minor. Now, this is the third case. Is a 62-year-old came with fatigue and dizziness and dyspnea, diagnosed diabetes in 2015, metformin 1 gram twice daily, and sitagliptin and beta blocker, no alcohol abuse or smoking. He was overweight, blood pressure was normal, capillary blood glucose 120. The glycemic control is very good, 6.8 HbA1c, and hemoglobin again 8.7. So what is the possibility? Now, when we look into the possibility, we have to check the mean corpuscular volume, and here we find the mean corpuscular volume is much higher, see 119. So patient has got a actually macrocytic anemia. So when we look into the macrocytic anemia, so quite naturally we have to find out the cause of the macrocytic anemia. And if we look into this algorithm, which I usually follow, and in the macrocytic anemia, we have two important cause. One is vitamin B12 deficiency, another is folate deficiency, and then we have the liver disease and hypothyroidism. This patient has no hypothyroidism, which was tested. The patient don't have any drug-induced cause of macrocytic anemia. It may be a drug-induced cause of macrocytic anemia, or vitamin B12 deficiency or folate deficiency. Now, when we look into the macrocytic anemia, so quite naturally we have to rule out whether it is a vitamin B12 deficiency, folate deficiency, or because of the liver disease. So we have checked the three. Liver function was perfectly all right, but vitamin B12 came very low, 113. So the patient is suffering from vitamin B12 deficiency, and often it is linked with that of the metformin therapy. So metformin therapy can lead to vitamin B12 deficiency, and which ultimately can lead to macrocytic anemia. So how we manage, as because it is possibly caused by metformin, hence we have to stop the metformin. We have started glargine to control the HbA1c level. We will replace the vitamin B12 intramuscular injection initially with 1000 microgram per week over the first 2 months, and then the doses being reduced to 1000 microgram every 2 weeks. So this is the way conventionally we treat the megaloblastic anemia. Now, when you are using metformin, so quite naturally the possibility of vitamin B12 deficiency and anemia is higher, and it is about 10 to 20% among the type 2 diabetic subjects. The metformin actually induces vitamin B12 malabsorption, and that is why the patient develops vitamin B12 deficiency. And if you give vitamin B12 more than 2 grams per day and more than 4 years, then there is a high possibility of development of vitamin B12 deficiency. And if the patient uses metformin, then quite naturally there is a 13% increased risk of vitamin B12 deficiency per year of total metformin use at 13 years since randomization. So these are the issues, these are the evidences in favor that the vitamin B12 deficiency can be caused by the metformin, and the people thought that they will look into the relationship of the metformin and the B12 deficiency further among the type 2 diabetic subjects. So this study, MASTERMIND study, was published. They have actually looked into the ADOPT trial data. They have looked into the UKPDS study data and a real world observational study data, GODARD study. So all these studies, they have looked into the relationship between anemia and the metformin, and it was found that the anemia is linked with that of the metformin therapy. And because of the fact that the metformin causes vitamin B12 deficiency, it is one of the most important explanation of the development of anemia with respect to metformin use. Now, this is a 54-year-old woman, diabetic for the last 14 years, hypertensive for 12 years, mother of one son. She was on diclazide, linagliptin, amlodipine, mild dyspnea on exertion, BMI 29, system examination normal, HbA1c 8.7, glycemic control is fairly good, but you can see the creatinine value is 2.71. As I have already pointed out, with the progression of the renal disease, the development of anemia is invariable. So therefore, this patient has developed anemia because of the fact that there is a chronic kidney disease in the backdrop. Now, if we look into the relationship between the creatinine clearance and the urinary ACR, you will find that there is progressive reduction in the creatinine clearance, and progressive rise in urinary albumin excretion is associated with significantly increase in the prevalence of anemia. So much so, if the creatinine clearance is lowest and the urinary albumin excretion of protein is very high, then almost 60% of the patient will have significant anemia. Now, the mechanism of anemia in chronic kidney disease is not one that is erythropoietin, though erythropoietin is a major issue for the development of anemia among patients with chronic kidney disease, but this is not the only issue for the development of anemia. Iron availability is another important issue, which is controlled by a liver hormone hepcidin, which level goes up, and therefore it interferes with the iron availability. Uremia itself can cause inhibition of erythropoiesis, and in an uremic subject there is a short in the red cell lifespan, and diabetic patient with CKD often have increased blood loss, because when there is an uremia, there is a possibility of gastrointestinal bleeding, and this increased blood loss further contributes to the anemia in chronic kidney disease. So we we had gone through further workup with this patient, and the creatinine again done, and it was 2.82. eGFR was calculated as 19. Transferrin saturation was adequate, and serum creatinine was 219, indicating that this patient has got an anemia, chronic kidney disease, but the iron store is quite adequate. So anemia with enough iron store. So how we manage this case? So if the patient has got an iron deficiency, then we have to treat the iron deficiency first. But this patient is not suffering from iron deficiency, so this patient will not require iron supplementation at present. As I've already told you, we will never overcorrect the anemia. Rather, we should target an hemoglobin level of 10 to 11 gram per day. That should be the optimum target. Next is that we should treat the patient with erythropoiesis stimulating agent, and we have two important options in front of us. One is epoetin, another is darbepoetin. So epoetin and darbepoetin are the two commonly used agents in the backdrop of chronic kidney disease, which improve the hemoglobin level. But we have to check about the adequacy of the iron store, so that will be indicated by transferrin saturation more than 20 and ferritin value more than 200 nanogram per ml. So we should start epoetin in a dose of 4,000 to 10,000 units subcutaneously once weekly, and then or we can give 10 to 20,000 units every other week. Either of these two is equally effective. And darbepoetin is given 60 to 200 micrograms subcutaneously every 2 to 4 weeks time. But the issue is that the giving epoetin or darbepoetin surely will correct the anemia in majority of the situation. However, they are not devoid of side effects. As you can see that these group of medication can cause rise in blood pressure, rise in hemoglobin, thrombosis, cardiovascular event, and malignancy. And that is why when you are treating a patient with erythropoiesis stimulating agent, be careful that you are not overcorrecting the anemia. If you overcorrect the anemia, the possibility of adverse event will go manifold, and therefore we should target an hemoglobin level roughly around 10 or 10 to 11%. Now the question is, if we correct the anemia, will it really helpful as far as the outcome is concerned, especially in the CKD patient? We do not have much conclusive evidence that correcting anemia significantly improves the clinical outcome in patients with CKD. Very recently, we had seen this trial, TREAT trial, which has looked into the use of darbepoetin alpha in type 2 diabetes and CKD, and they had tried to look into the outcome of the darbepoetin alpha injection, whether the death or cardiovascular event is reduced or not, whether the death or a renal event is reduced or not. These were the two primary composite outcome which was looked into the TREAT trial, and it was found that the darbepoetin alpha treatment is not associated with any reduction in the risk of either of these two primary composite outcome. Rather, it is associated with some increase in the adverse event, increase in the stroke. Having said that, I must tell you, we have limited evidences in favor that the correction of the anemia is associated with a better quality of life indices like ability to work, exercise tolerance, cognitive and sexual function, reduction in the retinal exudate and macular edema, reduction in the length of hospitalization in diabetic patient with heart failure, and the correction of the anemia actually protect against the development of diabetic neuropathy. So there are some benefits also, but at the same time, use of darbepoetin alpha can have some adverse events. So when we are treating the patient with erythropoietin stimulating agent, then we should be careful about our approach, that whether we will really get a lot of benefit without producing any adverse event or not. So so take home message for the day. Number one, in patients with diabetes mellitus, prompt detection and correction of anemia is important to reduce the risk of diabetic complications and to improve the quality of life. And iron deficiency, thalassemia, trait, vitamin B12 deficiency, and diabetic kidney diseases are the common causes of anemia in diabetes. Now, treatment with oral or intravenous iron preparation and erythropoietin stimulating agent needs to be individualized based on patient's clinical status, comorbid condition, and the risk. And fourth, is the excess correction of anemia, especially if you are doing it with erythropoiesis stimulating agent, could lead to adverse outcome. So thank you very much for your patient listening.